Okay, everyone, thanks for joining today. Hope you have some food to take you through this. Just going to go to where we left off last time. So as you recall, remember, most people remember that metabolic acidosis has two subcategories, but it's not the only one. Every acid-base disorder, you cannot write anything in the chart until you decide which of the two categories it is. And some of the are the same subdivisions, some are different. So, and in fact, as I said, metabolic acidosis and alkalosis, which is not shown here, you also have to write down whether it's compensated or not. Okay, we don't use that term in the respiratory acid-base disorders. So for metabolic acidosis, just to recap, everybody knows it's normal anion gap or elevated anion gap. Sometimes you'll see normal anion gap called hyperchloremic. It's the same thing. In the normal anion gap, when the bicarbonate falls, the chloride goes up. So the total of the chloride and bicarbonate stays what it was before, but the chloride is higher than it was depending on how much the bicarbonate went down. They go in opposite directions and in equal amounts. Whereas in an elevated anion gap, the bicarbonate goes down, but the chloride doesn't change. It's the unmeasured anions that go up. So that's sort of the concept. In the hyperchloremic, it's the chloride that goes up to maintain electroneutrality. In the normal anion gap type of metabolic acidosis, the chloride stays the same, and it's the unmeasured anions that go up to keep electroneutrality the same. That's sort of the concept. But the total anions, bicarb plus either unmeasured anions, like beta hydroxybutyrate or lactate, or bicarb plus chloride is what it was before. That total stays the same. In most situations, there are exceptions, but in general. Metabolic alkalosis, we don't divide up by anion gap. We divide it up by whether it will predictably respond to chloride-containing salts. And I say chloride-containing salts, not sodium chloride only, because it's been shown that other cations given with chloride will also make the bicarbonate return to normal in the chloride-sensitive group. Chloride-resistant group, you can give as much sodium chloride as you want. The bicarb is not going to come down. And we have ways of predicting that without having to do the experiment of giving chloride. We use the urine chloride, as I'll show you today, as a predictor of whether the patient will respond to your therapy of giving chloride or not. We want to predict that before we have to give the chloride in the real world. And there's a way to do that. But again, in metabolic alkalosis, please don't forget, for the rest of your fellowship, it's also compensated or not. You got to look at the PCO2. For every 10 increase in the bicarbonate, the PCO2 goes up by 7. That is what an expected response is. You don't call that a respiratory acidosis. That's a compensated metabolic alkalosis. If the PCO2 goes up more than 7 for a 10 increase in the bicarbonate, then you call it a respiratory acidosis. And conversely, if it didn't go up by 7, but let's say went up by 2 or 3, even though it's 43, you still call that a respiratory alkalosis. Now that's confusing for people. They go, how can it be 43 or 44? And I'm calling it a respiratory alkalosis. Well, it's a respiratory alkalosis because the normal number shouldn't be 40, it should be 47. So if the patient's PCO2 is not 47, it means they're hyperventilating if it's below 47. And that's what we mean when we say someone's got a respiratory alkalosis. So that's a confusing idea to people, but don't make that mistake. So you have to know what the expected PCO2 should be, and that becomes your new norm. You don't call that an abnormality. You don't call that a respiratory acidosis, because when you say respiratory acidosis to another person, you're telling them there's abnormality. And 47 is not abnormal. It's your new norm. That's what compensation means. It's the expected response in a human or most mammals. So everything above that is respiratory acidosis. Everything below that is respiratory alkalosis, even though if in an absolute numerical term, it's above 40, it's still respiratory alkalosis. So that's confusing to people, but as a renal fellow, you have to understand that, which the residents really don't. And you'll teach them, hopefully. You'll evangelize the residents when they see a case with you. Respiratory acidosis, we don't divide up by anion gap. We don't divide up by chloride sensitivity. We don't use the word compensated. We talk about a temporal subdivision. And that, I agree, doesn't make sense. We should call the chronic compensated and the acute not compensated, but it didn't evolve that way in the English language because of papers that were written in the 60s, 70s. So we're left with that. So never use the word compensated when you're talking about the respiratory acid-based disorders. It's temporal, it's acute or chronic. And the acute is immediate. It's like bubbling. Acute respiratory acidosis is like making soda stream or bubbling a solution with carbon dioxide. That's acute. That's just the bicarbonate buffer reaction. The bicarbonate goes up a little bit. Doesn't require a human body. The chronic is a different situation where the kidney starts generating more bicarbonate and adding it to the blood. And that's why the bicarbonate goes up further than just the acute situation. And the converse with respiratory alkalosis. Acute is like opening a bottle of Coca-Cola. The carbon dioxide leaves and the bicarbonate in the bottle drops a little bit. That doesn't require organs. And in the chronic situation, the kidney actually lowers the bicarbonate further. That's a more complex physiologic response. We won't get into that today. It's not simply dumping bicarbonate. And it's controversial depending on whether it's humans or dogs. They have a different response. But in all of them, the bicarbonate falls further than just the acute situation. If you have ESRD, it always looks acute. Remember that. In all these acid-base, in the two respiratory acid-base disorders, if you raise the PCO2 in someone with ESRD, their bicarbonate always just looks like the bicarbonate buffer reaction. They can't generate and add more bicarbonate to the blood because the kidney's not working. And conversely, in respiratory alkalosis, if you hyperventilate for some reason because you're with a new attending or you're afraid of something, and you have ESRD, you're always going to look like it's acute. The bicarbonate's not going to fall further because you don't have a kidney working. Remember that. So you lose the ability to tell the temporal state of the patient if you have ESRD and you have a respiratory acid-base disorder. You just don't have that information. Whereas if it's a normal human with normal kidneys, you can tell how long they've been hyperventilating, whether it's a few minutes or whether it's a number of days. So that's why it's clinically useful to divide up the acid-base disorder into two groups. It gives you an idea when a patient comes into the ER, how long they've been hypoventilating or hyperventilating, assuming they don't have ESRD. You lose that ability in a patient with ESRD. Always remember that. Okay, so we'll take another new patient today. And I'd like, the fellows to help out too. Please don't, worry about being absolutely wrong. It's the only way to learn. The human brain learns better when you commit yourself rather than just listening. So please feel free to unmute and say whatever you want. You're thinking out loud. So this is a patient, a 58-year-old male who was vomiting. And we look at these electrolytes. There's a dysnatremia. The sodium's lower than we would expect. The potassium's down. The chloride is lower than normal, although we don't think of that like initially. We'll use that to see if there's an anion gap. But the total CO2, remember, that's what that 36 is. Do not call it bicarbonate. Bicarbonate is only something you calculate from the blood gases. That's the total CO2. It represents all 4 carbonated species in blood. And it should have a negative sign when you write the total CO2, but no one does. Just never evolved that way. But remember, it's negatively charged, that 36. It's mostly bicarbonate, but it's also made of carbonate, which is micromolar, so we don't have to think about it. Carbonic acid, which is micromolar, so we don't have to think about it. And there's, at a PCO2 of 40, 1.2 millimolar of dissolved carbon dioxide in the blood. That we get from just multiplying the PCO2 times 0.03. Now, you can see the PCO2 is 47 here. So 0.03 times 47 is going to give us a little bit more dissolved CO2. So essentially, remember that 36 is a sum of the bicarbonate of 35 plus 0.03 times the 47. Those are the two entities within that total carbonated species that are in the millimolar range. We don't have to worry about what the carbonate or carbonic acid are in clinical medicine. They're just too low. And you can check the total CO2 to see if it indeed is above the bicarbonate by 0.03 times the PCO2. You should check that in every patient. So you take the bicarbonate from the blood gases, you add 0.03 times the PCO2, and it should equal the total CO2 if all three are correct. It's just a nice little check, internal check. Okay, so the bicarbonate's 30, or the total CO2 is 36. The bicarbonate's 35. That's expected. So because 0.03 times 47 is around 1.3, 1.4. That's about, what we'd expect. There's lab errors. We're not looking at decimal places here. The BUN is elevated. The creatinine's up a little bit. So, we look at this, patient's been vomiting. We'll just go through the thinking prior to the acid base. The dysnatremia is from the vomiting. Remember, the patient's ADH is high. They're going to be holding on to sodium and water, but a patient in this type of situations holds on to more water in proportion to sodium, so the sodium drops. If they were equal, the sodium in proportion, the sodium wouldn't change. So this is, a volume depletion type of hyponatremia, most likely. And we have a clue. We have pre-renal failure. The BUN's up and the creatinine, much out of keeping to the creatinine. So we have the dysnatremia as a clue, and we have the BUN to creatinine ratio as a clue. This patient's volume depleted. And remember, when we say volume depleted, we're talking about the intravascular volume. We're not talking about the total body volume. We're talking about a clinical term that refers to the expectation of having a drop in your blood pressure, a decreased JVP, maybe a tachycardia. Those are the clinical manifestations of that. These are the chemical correlate of that. We don't have the physical, but you would expect the patient would maybe have hypotension or postural hypotension. You might expect a JVP that's low. You might expect some tachycardia. But the chemical clues here are enough to say this patient's volume depleted, even if you don't see the patient clinically. Okay, so now what we're trying to do today and every week is to come up with the clinical acid-base diagnosis. And then after which is a chemical diagnosis of what we see in the blood. And then our brain goes to what is the cause of it clinically. We don't mix those two. The first thought is what is the chemical acid-base diagnosis in the blood, no matter what the cause. In this situation, you happen to know there's vomiting, so that is a cause of certain type of acid-base disorder. But in lieu of that, let's say we cross that out. Just you first look at the numbers and ask, does the patient have a metabolic acidosis, metabolic alkalosis, acute or chronic respiratory acidosis, or acute or chronic respiratory alkalosis? That's what we're doing now. We don't care about the reason for it yet. That we'll do in a minute. We have, in certain situations, like we discussed a minute ago, ways of parsing out subdivisions, which then each have a smaller number of possibilities. So we don't have to think of every single cause known to man. So first, our goal is to come up with what is the acid-base diagnosis. And so again, I'll do this one just to recap, unless does anyone want to take this on? Remember, you look at the bicarbonate or total CO2. Do not look at the PCO2. Do not look at the pH. You can choose the 36 or the 35. Okay, I'll go ahead then. So you look at the 36 or the 35 and you answer the next question in your mind. You have no other thoughts in your mind. The next choice you have to make is it elevated, normal, or decreased? Well, clearly it's elevated. So we pick, again, three choices. It's either metabolic alkalosis, acute respiratory acidosis, or chronic respiratory acidosis. Those are the only three possibilities for why someone's bicarbonate can be above normality. So how are we going to choose? We don't look at the pH. You're going to miss mixed acid-base disorders. We have to remember all the rules. For a given change in bicarbonate or total CO2 from normality, we compare that to the change in the PCO2 from normality. And those three choices that we just said are different, and we see which one fits our patient. Now, if none of them fit our patient, we a priori have a mixed acid-base disorder. If one of the three fits the patient, then we have our acid-base diagnosis. So the bicarbonate or the total CO2 is up. Assume this is a male, so best thing is to see what was in the chart last year when there was normality. But if we don't, we assume a normal of 25 from the human population. So it's up by about 10 or 11, something like that. So then we say, well, how much is the PCO2 elevated? If it's metabolic alkalosis compensated, it should be up by 7. If it's respiratory acidosis acute, remember, for every 10 change in the PCO2 from hypoventilation, the bicarb goes up by 1.5. Clearly, this is nothing near there. And for chronic respiratory acidosis, for every 10 increase in the PCO2, the bicarb goes up 3.5. Well, obviously, it's nowhere near that. Again, remember, with chronic respiratory acidosis, there's some controversy. Some people say it's for every 10 increase in the PCO2, the bicarb goes up 5. That's still an open question. So these numbers only fit a compensated metabolic alkalosis. Does everybody agree with that? Does anybody not see that? If you don't, please say so, because it's important you get used to this sort of sequential type of thinking of first what to focus on, and then what's the next thought. So again, acid-base diagnosis, look at the bicarb or total CO2. Is it up, normal, or decreased? If it's up, it's one of those three. Look at the change from normality versus the change in the PCO2 and fit one of the three into it, if it's possible to do so. And clearly, it only fits compensated metabolic alkalosis, which you would expect from vomiting. Vomiting causes a metabolic alkalosis. So let's talk about why it does. Well, we have to go back to gastrointestinal GI physiology, and we're now looking at the parietal cell in the stomach. And in order to understand what's going on in metabolic alkalosis, we talk about two things physiologically. So whenever someone has a metabolic alkalosis, we haven't talked about yet the subdivisions into chloride sensitive or not. We did talk about compensated. We divide metabolic alkalosis when you're talking to your attending into what are the causes for the generation of the bicarbonate. And then the second important question requires some knowledge of kidney physiology. And that is, why is the bicarbonate not being dumped by the kidney? Because if I just give you IV bicarbonate, it's all coming in your urine. It's very hard to raise someone's bicarbonate by giving bicarbonate with a normal GFR of 120 liters a day. It all comes out in the urine. You're maximally absorbing your filtered load of bicarbonate when it's 25. So you have to question that. Why is the kidney not dumping it? Even if we know the stomach is making it. So generation is what's making it. Where's the bicarbonate coming from, in other words? So it's either an internal organ, usually the stomach, although it can be the colon. We'll talk about that in later talks. Or it could be a human giving IV bicarbonate. But it has to be of a certain amount. If the stomach or the colon or the human gives a small amount, the kidney will be dumping it. So you can either have an elevated bicarbonate in a normal human because of the magnitude of the amount coming into the blood, or you can have the bicarbonate going up for a given input because the kidney is either revved up physiologically to reclaim that extra bicarbonate, or the kidney has a low GFR like ESRD. So when you have ESRD, all the bicarbonate coming into the blood, whether it's the stomach, the colon, or a human, is going to stay in the blood, right? That's an easy one, why the kidney is not dumping it. So remember that also. I think I said it last week in the context of something else. For any given input, if you have no output, we were talking about the anion gap with ketones and lactate. The anion gap is going to go up much more in someone with ESRD when they're putting this stuff into the blood and it can't come out. The same thing with bicarbonate in this context. If bicarbonate's coming into the bloodstream and you have ESRD, it's not going to come out. But even in a normal human, the volume depletion and the pre-renal failure and more factors, as I'll show, cause the normal kidney not to get rid of the bicarbonate. And we call that the maintenance phase. So let's get back to the generation. When you vomit, you generate bicarbonate in the stomach, in the parietal cells. And what happens here is you have the normal gastric acidification is created by a proton potassium ETPase. It transports a proton in one direction in exchange for potassium. It splits ATP, which is not shown here. It requires ATP to function. And when that proton comes into the stomach, you basically break apart carbonic acid just because of the bicarbonate buffer equilibrium, which is in every cell, it's everywhere in your body. You cause a directional release of proton and ultimately bicarbonate from this compound just because you lower the H concentration. So it's going to go in this direction. You generate bicarbonate. Now, bicarbonate doesn't come out into the lumen of the stomach. It actually leaves on the other side of the parietal cell into your blood on a protein called AE2, anion exchanger 2. It's a chloride bicarbonate exchanger. It's also in the kidney and the thick ascending limb and is important in the macula densa, which we'll talk about another time. But it's in many cells in the body. But in the stomach, it's how bicarbonate gets into the gastric vein. This occurs actually in something called the alkaline tide. Every time you eat, you generate bicarbonate this way in the stomach, and you actually have bicarbonate input into the blood when you eat, but you're not volume depleted. Your GFR is normal, and your kidney just dumps it. But it's called the alkaline tide. So this is the generation phase. This is where the bicarbonate came from in our patient. But it's not sufficient, which is why we now have to talk about the maintenance phase, because the normal kidney would just dump this bicarbonate like it does after you eat. But there's 3 sites in the nephron that are involved here that prevent the bicarbonate from coming out. One, you have a decreased GFR. We just showed the patient has pre-renal failure. So per unit time, there's less bicarbonate coming into the nephron here because you have, a third, let's say, less of a GFR. So every second, every minute, every day, whatever you want to use for the units of time, you have less bicarbonate coming through. So you're going to have, if nothing else happens, less coming out in that period of time. Secondly, the proximal tubule, because you're volume depleted, revs up its bicarbonate reclamation. Normally, it absorbs about 70% of the filtered bicarbonate. In this situation, it might be absorbing 85%. So not only is there less coming through, but of what does come through, more is absorbed back into the blood. And that's a complex story, what happens in the proximal tubule cell, which we won't get into today, but it's driven in part by angiotensin II going up when you're volume depleted. Now, this is a more subtle point for those of you that aren't familiar with this, but the collecting duct, the cortical collecting duct, a cell called the beta intercalated cell, actually secretes bicarbonate into the urine. There's a bicarbonate secretory process. We'll talk about that a separate time. But what happens is this doesn't work as well. In this situation, it requires a certain amount of chloride in the blood, in the urine, excuse me, in the luminal side. And when there's less chloride coming through, this thing shuts off. So you impair bicarbonate secretion. And that's another reason why the kidney can't dump bicarbonate in this situation. And that's one of the reasons when you give chloride, you correct the metabolic alkalosis. It's not just because you improve the volume depletion and improve the GFR and you shut off angiotensin II and you shut off bicarbonate reclamation of the proximal tubule. You also allow pendrin, the chloride bicarbonate exchanger that is in this part of the nephron that mediates bicarbonate secretion. You allow this bicarbonate secretory process to occur again. So chloride is really important. It's not for this process and has nothing to do with correcting site 1 and 2, which are more a volume depletion cause. Just to show you the cells in the cortical collecting duct, I don't expect you to remember this, but the cortical collecting duct has 3 different cell types. One secretes protons into the urine and absorbs bicarbonate on another protein called AE1, anion exchanger 1. This is actually mutated in certain types of distal RTA, which you'll learn during your fellowship. So it's a cause of hereditary distal RTA, and there's autosomal and recessive types. So that's a cell that actually secretes protons. There's another cell called the principal cell, where ENaC is the sodium epithelial sodium channel, ENaC, that amiloride blocks. This is the cell that's responsible for or potassium secretion on a separate protein called ROMK, not shown here. So this is involved in Little syndrome and giving amiloride, triamptorine, other genetic diseases where it actually can be increased or decreased. And then there's a sodium pump here, which we don't need to focus on. But this is the cell that's responsible for secreting bicarbonate, and it needs chloride in the lumen to do it. It's another third chloride bicarbonate exchanger we've talked about today. AE1 on AE2 on the parietal cell, AE1 on this cell, which is called a type A intercalated cell. And the type B intercalated cell that has penderin. Penderin's another type of chloride bicarbonate exchanger, but there needs to be chloride in the lumen. And when you're vomiting or volume depleted, chloride is absorbed avidly prior to this cell, and the luminal chloride drops low, and this thing just shuts off and you can't secrete bicarbonate. So it's another reason why the kidney can't get rid of the bicarbonate load that's coming in from the parietal cell. And that is another reason why giving chloride corrects the problem. Okay, so here is another patient on Lasix. Sodium's a bit low, potassium's low. I haven't talked about why the potassium's low. It's a separate lecture on the last two cases, but for now we'll just ignore it. The total CO2 is 34. It sort of matches the bicarbonate. The PCO2 is contributing again 0.03 times 45 above this. So it works out about right, that this is about 1 millimolar higher than this. Again, we have pre-renal failure, most likely. And so we'll forget the urine chloride for now, but let's just look at the acid-base status and make a diagnosis. So again, we look at the total CO2 or bicarbonate. It's elevated, so it's one of the three: metabolic alkalosis, acute or chronic respiratory acidosis. We look at the PCO2 and decide what are the proportions of this change versus this change. The bicarbonate, it's a male again, went up 8. So this should go up about 0.7 of 8, which is roughly what it went up. And so again, this is a compensated metabolic alkalosis. It does not fit the other two reasons for an elevated bicarbonate, so we don't have to focus on that. And so what we do in these situations, in addition to saying whether it's compensated, and we first decide whether the metabolic alkalosis will respond to chloride or will not respond to chloride. And we do that prior to having to do the experiment in the real world by telling the resident or the medical student, order a bolus of saline, see what happens. You shouldn't be doing that. What you first want to do is just order a urine chloride. If the urine chloride is in the normal range, and remember, this is just a ratio of their chloride intake to their water intake in general, right? So we ingest about 150 millimoles per liter of, 150 millimoles of chloride a day, roughly. It's roughly the excretion rate, and we ingest about 1 to 2 liters of water a day. So this is what you would expect the concentration to be. Remember, this is not an amount. You could do a 12-hour collection. You can also look at the fractional excretion of chloride. But what evolved was to look at the urine chloride. The fractional excretion is actually better because if you have a patient, let's say, ingesting 5, 6, 7 liters of water a day for some unknown reason, this could drop to 20, or, this, for the same amount of chloride in the urine, this will be diluted more and more and more and more. So it's not, what you were really looking for conceptually is how much chloride is coming out, not its concentration. So in a chloride resistant metabolic alkalosis, they're just in chloride balance like you are. Whatever chloride they take in, they excrete. But a person with volume depletion or many of the other causes of a chloride sensitive metabolic alkalosis, their chloride intake exceeds their excretion rate. They're not in chloride balance. The urine chloride concentration is okay to look at, but it also is reflected by how much water they drink in. So it's not perfect. You really want to know how much chloride is coming out, not its concentration. So the fractional excretion, remember, takes into consideration the concentration. It's concentration independent. We'll talk about what fractional excretion refers to another time. Or you can get a time collection and see that it has nothing to do with the patient's intake. Now, sometimes you could have a patient on a very low chloride intake, and that's why the urine chloride is 10 or 15 or 20. But that's not typical. I mean, let's say Bartter syndrome or someone on Lasix, they could be on a very low chloride intake, and this will look low, and you'll say, oh, it might be chloride sensitive. So it's not good just to look at this. You have to know what their intake of chloride is. The concept is that in the chloride responsive, the chloride excretion rate is less than their intake, significantly less. Whereas in the chloride responsive or non-responsive group, the chloride excretion is equal to their intake, no matter what they are, normal, high, low intake, but the excretion is equal to that. So the only reason I'm bringing that up is some people are fooled on tests or in the real world. They have a patient with Bartter syndrome or Gittleman syndrome or whatever the reason of Lasix, whatever the reason of a chloride-resistant metabolic alkalosis is, and the urine chloride's low and they're frustrated. How can that be? Well, number one, they could be on a sky-high water intake, so that diluted the chloride, even though the excretion is still, 100 or 150 milliequivalents a day. Or they could be on a low chloride intake, and that's why the chloride excretion is low. So you'll have to always think of that. It's like assessing the anion gap. Don't assess the anion gap without knowing what the albumin concentration is and what the pH is, two factors that can affect the anion gap independent of an acid-base disorder. Okay, so this is what you expect on Lasix, and the reason is you've impaired the nephron from, even though you're volume depleted, you've impaired the nephron's ability to keep chloride out of the urine, because you still have the prerenal failure, you still have angiotensin II, but Lasix is impairing the thick ascending limb chloride transport, and pendrin in the collecting duct is after that. So pendrin is seeing a normal chloride concentration, and it's going to secrete bicarbonate normally. That's one reason. And the bicarbonate's not going to go up as much, and you're going to see chloride in the urine. So for the same volume depletion, the bicarbonate is going to tend not to go up as much, because you still have pendrin working. That's another important point. Now, Lasix is a bit subtle too. So whenever you think someone might be a diuretic abuser as a cause of the metabolic alkalosis, your brain has to go immediately. Are they still on it or not? Because if they're still on it, yes, you'll see a urine chloride that's not low. But if they were on it and they stopped taking it, the kidney is going to rev up its chloride absorption ability. Obviously, pendrin will stop working because you've stopped impairing the thick ascending limb. They're still volume depleted, and they have to repair that. So they're going to be converted to what looks like a chloride responsive metabolic alkalosis. So diuretics, whether it's Lasix or thiazides, can look both ways. So when you have someone who is on diuretics, your brain has to go into this sort of subdivision. Are they actively on it? In which case the urine chloride will appear normal, or were they on it and they just stopped it a few days ago and now the urine chloride is low? Now, eventually, as they volume replete, the chloride will come back to normal again. They'll be in chloride balance. So they go through this sort of different phases. On the Lasix, the chloride looks normal. They stop the Lasix for the first few days, the chloride drops. As it drops and their volume depleted, the chloride will come back to normal by the third day or whatever, and they look like it did on the Lasix or when they're completely normal. Okay, I think I'll stop there for today. And does anyone have any questions or anything that wasn't clear?
I have a question.
Sure, go ahead.
I apologize. In the first example, the numbers added up, but you also said that the compensation is not correct. So I either missed something or, yeah.
No, I said it was correct. If I misspoke, I'm sorry.
Okay.
No, the compensation is what you'd expect, because the rule for metabolic alkalosis, again, it's a mean of many, many people. A given person can be different, but if you just take the average human population, the PCO2 goes up 7/10 of what the bicarbonate went up. In this case, the bicarb went up 10 roughly. The PCO2 should go up 7. No, this compensation is what you'd expect. The diagnosis here is a compensated metabolic alkalosis. That's it. You should write on the chart.
Thank you. Just wanted to confirm.
Now, I didn't mention one thing, and that is sometimes you get venous blood gases and sometimes you get arterial. And if you get arterial and the chemistry panel is venous, you may not get perfection here. This is going to be more than 2 or 3 higher than this, but don't be perturbed. Ideally, you would have the same type of blood for both. And as you know, we've said before, venous blood gases are perfectly fine for assessing acid-base status. And in fact, all the time we get this total CO2, it's a venous number. We never think of it. You could get arterial blood for this. We don't. The one number you have to know what type of blood it is the potassium, because there's 4 ranges for potassium. Venous serum has the highest normal value in the population. Venous arterial, venous plasma has the next highest. Arterial serum is roughly like venous plasma, and the lowest potassium, upper normal, is for arterial plasma. So for the potassium, you have to know what type of blood it came from, and people always forget that. They just assume, 5, 5.2, 5.3. That's my upper normal psychologically. You have to stop doing that when you're a renal fellow. You have to always ask, if a resident gave you or someone gave you a potassium number, what kind of blood was it? Venous serum, venous plasma, arterial serum, arterial plasma. It's the one number you have to really focus on that. And look it up, Google it. They each have their normal, upper normal value. The hospital, fortunately, won't do that.
This might be a remedial question, but in terms of the actual blood draw and how it's run in the laboratory, what's the difference between plasma and serum? I thought when you place the order, everything is always run off of separated and it's just serum.
You can ask for plasma if you want. As far as I know, unless something has changed.
Okay.
I might be wrong, but that's an important point you make.
Okay.
There are instances where you want plasma. And so as far as I know, that can be ordered. If it's not, let me know. I'll speak to the head of the chemistry on that.
Okay.
But in general, when you're in Mintry's clinic or you're on the ward and someone confronts you with an abnormally elevated potassium, the low, it doesn't really matter clinically. Although the low, it actually can come into play because the lowest number will be in arterial plasma. The lowest normal value you'll accept is in arterial plasma. Whereas in, venous serum, that number may look normal, in the normal range. So you just have to know the low and the high and memorize them or keep them on your phone. It's something people don't think about. It affects how nervous you need to be.
This is another remedial question. I apologize, but why don't we refer to the kidney's ability to adjust to like a respiratory process as compensation?
We don't. The point I was making is with the respiratory acid-base disorders, you don't use the word compensation. You don't use the word compensation, sorry. I'm going the wrong way here, sorry. We don't use the word compensation in the respiratory acid-base disorders. We use a temporal subdivision. You could use the word compensation because when, let's say now, you got nervous for some reason and your PCO2 drops from 40 to 30. If I measure your bicarbonate initially, it'll fall by about 1.5 to 23.5. But if I keep measuring your bicarbonate over the next 3-4 days, even though your PCO2 is still 30, it's going to end up being 20. And the reason is the kidney does a number of things, and in the new steady state keeps the bicarbonate at 20. Now you could call that, and no one would criticize that, at least conceptually, a compensation. You are returning the pH closer to what it would be otherwise. If the bicarb stayed at 23.5, the pH is going to be higher than when the bicarb falls to 20 chronically. The pH is returned more closely to normal. That's what the word compensation initially referred to. It's the bringing the pH closer back to 7.4. And that's what the kidney is doing. So no one could fault you. It just didn't evolve to use it for that term. We use that term to refer in the metabolic acid-based disorders to what the lungs are doing. When the lungs ventilate properly, we call that a compensation. But in the respiratory acid-based disorders, the question is, what's the kidney doing? The lung is the initiator. It can't be a compensator. In respiratory acid-based disorders, it's the primary event causing the acid-based disorder. What the kidney does in response to that could be called a compensation. Did that answer your question? I'm not sure.
It did, because first time I heard you say it, I thought there was two different physiological processes, something that the lungs can and cannot do, and then there's compensation. But it just sounds like this is just nomenclature. So
Yeah,
I understand better now.
Yes, no, in the respiratory acid-based disorders, the lungs act abnormally. And we call that acute or chronic respiratory acidosis or alkalosis. The kidney is the responder to that abnormal change by the lung. And either it'll do something, and if it does it appropriately, we call that chronic because it takes 2 or 3 days. We could call that a compensation, we just don't. If you have ESRD, it will not do it. Maybe that's what you're referring to. ESRD prevents the kidney from responding. So it always looks acute. In the metabolic, the bicarbonate or the kidney is the initiator. And so the compensation refers to what the responder is, which is the lung. The lung either responds normally or it doesn't. Now, that's an important point. And I've said that a couple of times, that in the metabolic acid-based disorders, when the lung doesn't respond as predicted, in other words, it's saying it another way, we don't have the appropriate compensation, then by definition, you have a respiratory acid-based disorder in addition. Could be, alkalosis or acidosis. It depends what the PCO2 is. But if the PCO2 isn't what it should be, in other words, there wasn't the compensation that we predict, by definition, you don't just stop there and say, this is uncompensated. You have to also say that the patient, in addition to the metabolic alkalosis, has a respiratory alkalosis. That's what it means when the PCO2 isn't what it should be. You're conveying to another human brain that there's a mixed acid-based disorder, which means more than one. So the lack of a compensation, a priori, or by definition, means a mixed acid-based disorder.
Thank you so much.
Okay, everyone, I'm sorry we started late. If anyone has any questions or anything that I wasn't clear about, please feel free to text me or call or email. We'll get back to you. Have a great day.